All right, good afternoon, everyone, and welcome to the first episode of our Colleague Connection, a live event where we've gathered a panel of experts to answer and discuss your questions, comments, and the most relevant topics of today. My name is Paul Larkin. I'm a content manager for Pure Encapsulations, and I am your host today. I'm going to kick things off for us right now, but before I do, there's just a quick disclaimer that I have to make, and that is now on your screen. So this seminar is for educational purposes only. It's intended for healthcare practitioners only, and the opinions of our three panelists here are their own and do not necessarily reflect the opinions of the company, which is good. We haven't told them to say anything. They're here on their own volition, saying what they want to say. So with that said, please allow me to introduce you to our three panelists. We're joined by, in the bottom right-hand corner of my screen, Dr. James Greenblatt. Dr. Greenblatt, if you could just wave at the screen for me, who is dually board certified in both child and adult psychiatry. Currently, he serves as Chief Medical Officer at Walden Behavioral Care, which is a private psychiatric hospital treating eating disorders and other psychiatric patients. He's also a clinical faculty member in the Department of Psychiatry at Tufts University. He's here today to help answer questions pertaining to mental health. So for example, what can we do for ourselves to keep positive and emotionally well? And also, what can we recommend to our patients, especially those with existing conditions? So welcome, Dr. Greenblatt. Thank you for joining us. We are also joined by Dr. Caroline Cederquist, who is a board-certified bariatric physician and founder and medical director of the Cederquist Medical Wellness Center in Naples, Florida. Dr. Cederquist is here both as a clinician to help explain the biology of satiety and why I can't seem to stop snacking all day, and also as a businesswoman. Dr. Cederquist has been in private practice for several decades and has lived through many recessions in the past. So she's here today to answer all of your questions regarding your business and how to keep it afloat even during these economic downturns. So we're very grateful to have her here with us. Welcome, Dr. Cederquist. Last but certainly not least, we are joined by Dr. Sam Yanuck, who is a functional immunologist, really a pioneer in the field of functional immunology. We're very lucky to have him. Dr. Yanuck also has a private practice. He's located in Chapel Hill, North Carolina, but you probably know him from his online educational course called Cogence Immunology. Seriously, if you haven't checked this out yet, you really should. He's the founder and director of that online course. He's also an adjunct assistant professor at the University of North Carolina School of Medicine, and he's here today to, of course, speak to the immunology of this pandemic, how this virus works, what makes it unique, what we can do about it. So Dr. Yanuck, thank you for being here as well.
It's a pleasure.
All right, so I want to take a moment before we jump into things to extend a thank you to our attendees as well. There are seriously over 600 of you right now tuned in, and the willingness of so many of you to come together and share this experience, your struggles and your successes in this difficult time is really remarkable. And I'm very grateful to be part of this ever-growing community of doctors and clinicians and people that we have with us here today. I think we're very fortunate. Not a lot of industries have this community that we have, and not a lot of organizations have this community. So I wanted to thank all of you for taking the time out of your afternoon to join us. I know things can be a bit crazy right now, so we appreciate it. I also want to take a moment to thank everyone behind the scenes here. Kelsey Staffstrom is our woman behind the curtain. She is making all of this possible behind the scenes, so a big thank you to Kelsey. To reiterate how this is going to work, let me move us along here. Here are our panelists on the slide. To reiterate how this is going to work, we have nothing prepared for you guys. So this is entirely based upon answering your questions and responding to your comments. So with that said, actually, I take that back. Dr. Yanuck does have a few slides for you, I think, to clarify some things. So we do have a little bit of material for you, but predominantly we're here today to answer questions and to share our experiences, what's working, what's not. So to ask a question, please use the question feature on the GoToWebinar control panel. Okay, we have a team here on the back end who's going to filter through these questions and try to provide a little structure to today's talk, so we're not jumping around too much. So we'll try to answer a bunch of immune questions, a bunch of business questions, a bunch of mental health questions, so we can get a good, nice, clear picture of each one of these topics. So questions should go into the questions feature on your GoToWebinar control panel. Now there's a chat feature as well, and we encourage you to use that. You can put comments in here. So we have 3 experts with us here today, but there are tons of experts in our as attendees right now. So I'm sure many of you have discovered things that are working well for you, maybe things that haven't worked, you've tried and they didn't work. So if you have a comment to share with the rest of the group here, please feel free to share that in the chat feature on the GoToWebinar control panel, and you can share that with everybody else who's here, and we can all learn from each other's experiences. So I encourage you to do that as well. Lastly, for the sake of time, I will try to direct questions to each one of our panelists, but to our panelists, please jump in whenever you want. We're here to learn from all of you, so we, don't feel like I need to call on you in order to say something. So we did it. Let's get started. The first question is coming from me. It's the only question coming from me today, and I will open it up to all of you. It's a general question. I just want to get a sense for how you're doing. So Dr. Greenblatt, maybe you can start with this and we can kind of go through the rounds. I just want to get an idea of how you're doing during this difficult time, how this is affecting you, and how this is maybe affecting your work life as well. Ooh.
There we go. Sorry. At this time, I'm going to a inpatient hospital every day, 5, if not 7 days a week. So our programs at Walden divided our day programs. We were able to switch to virtual, but we have 65 hospitalized psychiatric patients that can't go virtual. So my life has been stressful. I have a staff of 25 doctors and 200 employees walking in, treating patients without adequate protective gear, and dealing with my anxiety and the staff anxiety and the patient's anxiety has been challenging and a learning experience. And I hope to share some of that with the group.
Yeah, wonderful. Thank you. Dr. Cederquist, how are you doing?
Yes, thank you. So our practice went over to virtual telemedicine probably Tuesday of last week. So it's been more than a week. The decision was made because a lot of our patients travel extensively. Just the risks seem too high. So the clinical staff is really working from home doing telemedicine. The rest of the team is in the office actually helping people who are trying to order products, making them available for pickup, scheduling appointments. It's definitely something we've never seen before.
Yeah. And Dr. Yanuck, what about you?
We've been telemedicine only since March 7th or so.
Oh, wow.
Yeah.
Okay.
And I've been home. I'm working pretty much all the time that I'm awake, except for meals and being on the treadmill or the stationary bike, which have turned into these little oases of relaxation. So
good. That's important.
Yeah, exactly. So I think self-regulation, and I think Dr. Greenblatt will tell us this, self-regulation is very, very important. You're not going to be any good to your patients if you're not, if you're not taking care of yourself. And I think just being purposeful rather than anxious is how I'm trying to handle it. And I seem to be doing pretty okay so far that way.
Good. I'm glad to hear it. All right, well, let's dive into, I think, probably the most pressing matter here, and that's the immunology of this. So Dr. Yanuck, I think this is predominantly for you, but to our other panelists, feel free to jump in if you see fit. Could you quickly review for us, Dr. Yanuck, what we know about the pathology of this virus and what makes it unique, and what should we know about this?
Sure. Well, I think we have a combination of things that are specific to this virus and things that we know about the immunology in general. And one of the temptations that we have with this particular virus is to say, oh my God, this is so unique, we've never seen it before. So let's try to find out all the cool new stuff. And if we do that, but we forget about what we know, then that's going to be a mistake. Mm-hmm. So we want to combine fundamentals of how the immune system works with the particulars of what's known about this virus. Now, one of the things known about this virus is that it's similar to SARS-CoV-1 and similar to MERS. So lessons that we learned, especially with SARS-CoV-1, will be quite useful to us. And just for the sake of nomenclature, this is a SARS virus. What we called SARS was SARS-CoV-1. This one is SARS-CoV-2. That's the name of the virus. The name of the disease is COVID-19. So just like there's the HIV virus that causes AIDS, not everybody with HIV gets AIDS, right? So when you hear people talking about COVID-19, that's the disease that is caused by the virus SARS-CoV-2, okay? So in this particular virus, you have two questions, okay? Because people can die of this virus, you have two basic questions. One is, how do you not get the virus? And then the second question is, how do you not die if you get the virus? Right? That's the basics of the landscape here. Okay. Now, one of the things that has happened is that a question has arisen about who might have a fatal case of the virus. And the first thing we have to talk about, I think, is transmission. Okay, so just a couple of facts. It's about 5 days between becoming infected and having your first symptoms. That means that people can walk around not knowing they are infected and infect other people. So if you hear things like, oh, if you can exercise vigorously, you're not infected, that's completely not true. Okay, so you'll have no symptoms for 5 days or so, then you'll have your first symptoms. Generally speaking, the time between your first symptoms and when you have a crescendo of symptoms to the most vigorous symptoms is about a week, about 7 days.
Wow.
So, so that's sort of the choreography of it. Okay. Now the tricky part is this: there are plenty of people who get the infection and it doesn't give them symptoms at all, or it might give them very, very mild symptoms, so that they are walking around, they don't know they're infected. They get those first 5 days to first symptoms, but the symptoms are so mild, they don't know anything's happening. And they only get a realization that they're infected sometime during that 7-day crescendo. So for some people, they may feel like they had some symptoms that lasts a couple of days. And then if what I said about 7 days makes you feel like it couldn't have been the COVID-19 infection, the COVID-19 disease, because you only had symptoms for a few days, that would be a mistake, right? Recognize that you may only be aware of your symptomatology at the crescendo. So there's a lot of navigating you have to think through here to decide what the observations you make mean about the virus and about the disease, okay? So that's one thing. Then back to our main two questions. How do you not get it? How do you not die from it? Okay. Now, how do you not get it? That's a function of what's true about viruses generally, right? The very first thing is don't get exposed. So probably one of the most important things I can say to you today is stay home, okay? It's very tempting, I think, psychologically to find reasons to decide, oh, this is not a big deal, you know, everything is overhyped or things like that. And because it's very hard to find good information on the internet or on Facebook, things tend to get turned into controversies with alternating views instead of, hey, what are the facts? And that's a very unproductive thing, of course. Because of that, and because I think there's a strong psychological pull to say, oh, this is not going to be so bad, we tend to look for ways to get ourselves into the conclusion that it's not going to be so bad. That's a mistake. We don't know. Now, so stay home. The big way to not get infected is to stay home. Okay. Now, second thing to do is to support the aspects of the immune system that we know help you not get infected or fight off infection successfully. That means activation of natural killer cells. And that means activation of the Th1 response. Those are the ways that you have a robust immune response against a viral pathogen. Right? Natural killer cells help you kill virally infected cells. Th1 cells promote natural killer cells and promote cytotoxic T lymphocytes, CTLs, which are the killer CD8 T cells, right? So decades ago during the HIV, the AIDS epidemic, we thought that CD8 cells were suppressors. They're not suppressors. That nomenclature sticks around but should not. Okay, so CD8 cells are cytotoxic killer T cells. They're promoted by Th1 cells. So that's a basic piece of it. Now the other part though, how do you not die, is that you've got to stay quiet enough in your inflammatory process. And for that, I'd ask you to just show the first slide.
Sure.
All right, click about 4 times if you would.
Mm-hmm.
So on the vertical axis, you have inflammatory status at baseline. Horizontal axis, you've got time. If the extent of your inflammation at the beginning of getting the infection is modest, then the crescendo of inflammatory process you get that is inherent in any immunological response to try to kill pathogens, that's going to bring you up by some amount. You'll get that crescendo and then decrescendo, and everything's fine. Click twice more if you would, please, Paul.
Sure.
But if your level of inherent inflammatory baseline is greater, then when you get the viral infection, the crescendo will bring you up to a higher point. Go ahead and click, Paul. So that, click once more, so that you could get closer to having ARDS, which is acute respiratory distress syndrome, which is how people get into trouble and have greater risk of fatality.
So it's just to clarify, so it's really the baseline level of inflammation that is a large risk factor for whether this can become serious or not. Is that right?
That's a big piece of it. Now we're going to discover things we don't know yet that are also risk factors that are genetic and epigenetic and have to do with pieces of this that we don't know yet. But this is a very fundamental thing that has to do with the discussions going on about who is at greater risk, people with hypertension, diabetes, things like that. And this sense of a greater inflammatory status at baseline is very, very important. And so the entire endeavor has to be framed in terms of 2 things. One is you want to create efficiencies in the immune system so you can kill pathogen. The other is you want to make sure you have enough headroom so that as you help the immune system evoke the ability to kill pathogen, the inherently inflammatory effect of that doesn't bring you up so high that you risk ARDS. That's the fundamental balancing act. We can click maybe 3 more times there. So you want good surveillance, and especially you want to get rid of non-purposeful inflammation, right? So get rid of the things that all of us in the functional medicine world know how to do, which is get rid of bad foods, get rid of bad stress, get rid of insomnia, get rid of excessive training intensity, all those kinds of things. Get rid of any inflammation that isn't helping you kill pathogen. Non-purposeful, non-aimed inflammation isn't helping anybody. Go ahead and click 1 more time if you will. So if you can bring the overall inflammatory quotient down, then you bring the crescendo of the purposeful immune response against the pathogen down as well, and it becomes safe to kill virus without worrying about spinning up too high. Okay, that's the game.
So I think the natural question then is, should we be using anti-inflammatories? Should we be taking things like fish oils and curcumin, things to try to quiet the immune system? And the answer is yes.
Yes. And it's also been shown that non-steroidal anti-inflammatories are risky or problematic because their persistent use doesn't advantage you in terms of the chemistry that helps you resolve inflammation. The recommendation that's been given is for Tylenol. That's a reasonable recommendation, except that Tylenol is known to deplete glutathione. And glutathione is essential for reducing lung inflammation. Now, here's a cautionary point. I don't want everybody who's on this webinar to go buy a ton of glutathione and start giving it to all their patients, because the glutathione supply within our community will be quickly depleted to zero. And then it will not be available for people if they get in trouble. Okay, if you have glutathione, if you want to get glutathione, that's fine, in proportion to how much you would actually use. And if you're going to give it to patients, unless it's people who are 75 who have COPD or something, you want to have it in reserve in case people get into trouble. You don't want to start dosing people with glutathione prophylactically. It's going to all be gone, and you won't be able to actually help the people who are in dire need.
Mm-hmm. And so those people in dire need are the elderly, those with existing conditions. You mentioned type 2 or type 1 diabetes and elevated blood
Diabetes,
pressure.
heart disease, things like that.
Okay.
And to that end, let's just take a moment or two to answer what I think is the most important question, which is about ACE inhibitors and angiotensin receptor blockers. And then I'll relinquish the floor to whomever wants to take it. Go ahead to the next slide. Okay, let me just say a word about this. On the left, you have normal. Normal is the yellow, which is the infection. The green is the inflammation. The pink is the resolution chemistry. In B, the middle, the intensity of the inflammatory component of the immune response is too high, and the resolution chemistry fails to quiet it. That's a danger of acute respiratory distress syndrome, ARDS. On the right, you have a different version of that where the resolution phase chemistry is too intense. People with too much TGF-beta in their blood work, like over 4,000 or 5,000, might have C. There'd be reason to think they might have C, where there's not enough intensity of immune response to kill the pathogen. Those are people for whom botanicals that are very activating of the immune response might be most especially appropriate. Okay, go on to the next if you will. I'll just skip through to the next slide. There you go. Okay, a point about ACE inhibitors and angiotensin receptor blockers. There is a receptor on lung cells, lung epithelial cells, called ACE2. The virus enters the lung cell via ACE2. So people have said, let's reduce how much ACE2 people have by getting them off their ACE inhibitors and angiotensin receptor blockers, because those drugs increase ACE2. The problem is this. The reason people are saying that is because people with hypertension and diabetes and obesity die more from this infection. The reason they die more is because they have underlying disease that is greater, not because they're on the meds. That's like saying, geez, all these people on heart disease medications die of heart disease. Maybe it's their medications. No, it's not. Okay. The reason these people die is because the inflammatory process that drives their coronavirus is driven by this NLRP3 inflammasome. Next slide, please. Skip that. Skip all that. Skip all that. Skip all that. No, this is the mechanism of the inflammasome. Skip all that. Skip that. There you go. Go ahead and hit the thing 4 times, 4 arrows. There you go. Do you see how on the top left, this is from Nature, by the way, the top left is macrophages in fatty tissue. Well, what's in there is inflammasome activity, NLRP3 inflammasome, just like SARS-CoV-2. And you see the top in the middle with heart disease. What do you know? It's macrophages and their NLRP3 inflammasomes driving their heart disease. And on the bottom on the right, their diabetes. Also, there's the NLRP3 inflammasome. The people with these diseases have already an upregulation of NLRP3 mediated inflammasome activation. So of course they're going to be closer to the threshold of going up in flames in terms of ARDS. That's not because the medications that they're trying to get help from are doing it. It's because those are the diseases where they're going to go up in flames with their disease. You can stop the PowerPoint stuff. Now, the ACE inhibitors and the ARBs, they increase ACE2. What's true is that the people with SARS-CoV-2, it's been shown, the ones who die have the poorest ACE2 expression. The ones who survive have the better ACE2 expression. So if we go back to our two basic questions, how do you not get the disease and how do you not die? The basic question, the key question is how do you not die? The way you not die is you have enough ACE2 expression that you don't get ARDS. So please, please, everyone, do not take people off these medications, okay? That's not just me saying it. I've been talking all week and for 2 weeks to MD, PhD immunologists who are well published in Lancet Respiratory Medicine and so on, who run research labs, run respiratory immunology research labs, deal with patients all the time. The consensus among people who know how the lungs work and know how these medications work and deal with that every day is, oh my gosh, don't take the people off those medications. The medications are protecting them against dying from the infection. Okay, that's what I got.
Great, Dr. Yanuck, thank you. So the take-home message is don't take them off the medications and do what we can to lower systemic levels of inflammation using all of the functional medicine tools that we are all knowledgeable of and accustomed to using. One of those being supplemental glutathione or potentially glutathione precursors. So I want to stay in the lane of immunology just a little bit longer, and then we will switch over. But to answer some of the incoming questions that we're getting regarding glutathione, would it be appropriate, Dr. Yanuck, to take something like NAC or to boost NRF2 activation in an effort to increase endogenous glutathione levels? Is that worthwhile?
Yes, certainly true. One of the disadvantages we have is that we can't do a lot of lab testing of people who are not in the room with us, or people we don't want to send out into the world. So we have a bit of a disadvantage there. But certainly NAC, NRF2 promoters, all of that is very, very appropriate. Generally, we're looking for supplements that advantage both of our two goals. The goal of promoting and supporting immune surveillance and the goal of quieting down inflammatory activation. So for example, vitamin D is necessary for macrophages to make lysosomal enzymes. Your macrophages can't work unless you have enough D. And also vitamin D is very anti-inflammatory. A is like that, C is like that, zinc is very useful. Things that are Th1 promoters and natural killer cell promoters, because they inhibit Th17 cytokines, are like that. So Th17 cytokines will get you going with very extensive neutrophilic inflammation, and regulatory T cells and Th1 cells both quiet that down. So all of those are significant advantages.
Okay, you mentioned vitamin D. Have you heard of vitamin D's ability to act on ACE2? Is that something that you're...
Yeah, so there are animal studies that show that D can act on ACE2. There are 3 human trials where they tried to make use of vitamin D to promote ACE2. All 3 of them failed.
Oy.
There was an AFib trial that failed, there was a hypertension trial that failed, and there was a diabetes trial that failed. So what that tells you is, in humans at least, the evidence is that you're not going to have a big effect on ACE2. Now, what we should all think of that is, we should all be disappointed because we understand that ACE2 is protective. The people who say, don't use D because it might increase ACE2, the two reasons that I disagree with that and that my colleagues disagree with that is, first of all, because vitamin D is not going to have an appreciable effect on ACE2. And the second reason is because, darn, we wish it would have been able to increase ACE2.
Right. You mentioned earlier that the virus is basically able to evade, or maybe not evade, but there's no expression of symptoms for the first 5-7 days. Do we know why that might be the case? Why is it?
That's not within my expertise. I don't know the answer to that question.
Yeah. Okay. No worries. So next question I have is here. Social distancing. We're all trying to flatten the curve, right? What is to, at some point we have to stop social distancing? What's to stop the virus from becoming, back with a vengeance when we stop social distancing, when we open up the stores again and everyone starts to go about their daily lives, there will be a number of people who haven't gotten it, right? And are we suddenly going to cause a spike in the number of cases?
Well, the point of flattening the curve isn't ultimately to change the number of people who get the infection. It's to spread that out over a longer time so that intensive care units are not thoroughly inundated and overwhelmed. And if you have colleagues, as I do, who are connected to the intensive care unit doctor community, that's happening. So when people say, "Oh, this is overblown," or "It's not a big deal," "It's not going to," the regular flu causes more deaths, so this is being overblown, and conspiracy theories like that. The regular flu every year does not overwhelm and inundate intensive care units. This flu is doing that. So please don't play some sort of numbers game to convince yourself nothing's happening here. That's not an accurate way to view it. So the goal is, because this is so infectious, even with social distancing, a lot of people who are trying to not get this are going to get this. What's then going to happen is that they begin to build the numbers for herd immunity. Now, one of the smartest things I've heard said so far is from an MD PhD immunologist named Peter, I believe his last name is Hotez, spelled H-O-T-E-Z. And one of the things he said was, one of the substantial turning points will be when enough doctors and nurses have recovered from SARS-CoV-2 infection, that they are immune,
Right.
so that people going into hospitals will not be infecting the care worker population. That's a very important point. But we're trying to spread these points out, and making maximal best efforts to do that is the move. All of the trains of thought that say, "How about if I go out now?" The answer is no. Okay?
All right, understood. I want to switch gears here and jump into the business side of things and talk to you, Dr. Cederquist, about telemedicine, about good business practices in economic downturns. You told me a story actually that I was unfamiliar with about how a hurricane hit your office back, was it Hurricane Harvey? Can you tell the audience? Irma,
yeah,
thank
so
you. Can you tell the audience
2017, yes. So September 2017, our office was closed for a month after Hurricane Irma. It actually was a direct hit over our house and the office. And while there was damage to mostly, some homes, but mostly a lot of trees, there was actually no power in the office, which caused mold issues, which had to be remediated. And then we had no internet for a month. So we have an electronic medical record. No one can do anything. And kind of the point of it is that, we don't know how long this is going to last and the extent that we'll need to transition our office to telemedicine. But at least we were able to survive a month and get through it. And I was shocked that I actually did get a check from my insurance regarding business interruption. I never would have thought I would gotten any money for that in a million years, but I was able to pay my staff the whole time and was able to get some money back. I do think, with one of the things that Dr. Yanuck said that's so important is in the work we do, a lot of times people can think of, weight management and losing weight. It's kind of like an elective thing. You do it because you want to look better, feel better, but it's not important. But if people really have these higher levels of inflammation, the insulin resistance, the prediabetes, all of these things, then they really need to get that they have to do these lifestyle changes despite the fact that our lives are being disrupted.
Yeah.
For the past 23 years, we always did some small degree of telemedicine, meaning our patients would come and they're like, "I want to lose 30 pounds and I'm leaving in a month." Well, no one loses 30 pounds in a month. So we're going to work with you from home. And back in the day, it was regular phones, and then it was iPhones and FaceTime. And, now there are some various telemedicine health platforms. I will say we always had some patients who did it, but it wasn't as popular as kind of coming into the office and facing the music, patients would say. I want to get on the scale and all of that. But it's probably even more important now to have the regularity of visits with patients who need support, who are fragile, who get into emotional eating, stress eating that Dr. Greenblatt knows so much about, that we certainly see. And as Dr. Yanuck is saying, this is not the time to say, I'm just going to drink alcohol, I'm just going to eat my sugar, I'm just going to, give up on the things that have been successful for me because I'm afraid. So the utility of reaching out to our patients is all that much more helpful. I will say I'm particularly grateful for the fact that our practice has always sold some products. It's helping. It's allowing our patients to be on a program, and it's allowing the practice to actually have some money coming in addition to trying to keep patients on a telemedicine program.
So you mentioned selling products. Is that, how are you doing that? Are you using, and what are you selling? Are you selling supplements or books, or?
Yeah, primarily, it's supplements, but our practice has always sold food as well. We have some protein powders and protein bars. Those can be shipped, but we're having some people, drive up and we have it ready for them, that type of thing, so that they aren't coming into the office. The products, we have always stocked a lot in the office because we had a busy practice. But now we're, ordering it for them and having it shipped directly if we're not able to ship from the office.
Got it. So these alternative revenue streams are really, they're helpful always, but they're more so important now than ever. And you're able to ship these directly to the patient, which I think sounds great. What's not to like? And then to go back on one of your points, you mentioned that you found that reaching out is more important now than ever, or being, having routine contact with patients is more important now than ever because everyone's routine is disrupted. Can you confirm that am I recalling this correctly? And how are you doing that? How are you executing that in your practice?
So our practice has usually had our weight management program, our lifestyle change program was like a 12-week program where we would see patients every week. And usually it was in person, but sometimes it wasn't. We've had patients for years who would come to Naples for 1 or 2 visits, and then everything would be done virtually. But they would have a formal appointment. So the appointment that somebody has at 9 o'clock in Arizona is taking the same amount of time that we set aside for a patient in Florida. So they actually have a formal appointment. But for so many patients who struggle with weight management or just taking good care of themselves, they really need accountability. They're very smart people, but they put themselves last, and it's when they make a commitment that somebody else is going to hold them to account, they actually do so much better. So while people will say, well, I don't want to come in, I only want to come back once I can walk through the door and get on the scale and this and that, that's probably not the best answer. We should try to really convince them to try to keep some accountability during these times so they don't move backwards and become more inflamed. Because as Dr. Yanuck is saying, more people are going to get the virus. We're just trying to flatten the curve. We're not thinking in 2 weeks it's magically gone.
Yeah, right. And so how are you collecting fees for these online appointments? Is it out of pocket? Are you able to go through insurance?
Our practice, has really been for more than 23 years, fee for service. It's a cash program and people pay in advance. So whether they do their visit in person or virtually, it's the same. So while it may be challenging to try to transition to that when it hasn't been for another practice, these are different times. And patients before would be like, oh, I don't want to do a visit virtually. Now they actually do want care and they don't want to come in. They don't want to be exposed to a waiting room of patients any more than we don't want to be exposed to everyone they're exposed to. So it's potentially an opportunity to get more functional medicine to other patients who may have been less wanting to do that in the past.
Yeah. So are you seeing a decline in patients? Are you seeing an uptick in patients? What are you experiencing?
Yes. What we're actually seeing is that we've been able to retain a lot of our long-term patients, the ones who valued it, or even people who are, somewhat in the program. What we're not seeing is new patients. So, so in our practice, there's always the influx of new patients, but I don't even think that it's a telemedicine issue so much as it's like, weight management is something that, you know, is elective. That's like something for when I have extra money. It's not critical to my health, you know, or people know it's critical, but it gets to a point where they can't take it anymore.
Yeah.
But we've seen that every single time, like after 9/11 in 2008, you know, where there was a lull, where people were like afraid, the stock market fell, they don't have the, you know, the disposable income, but then over time, the fact remains that they continue to have these comorbidity and problems, and then they realize that they do need help. So a practice that's able to get fluid and be able to help with being able to service these patients will hopefully survive.
Yeah. So it's, I mean, patients will come back and we will all get through this. And you mentioned having, you know, a strong central group of patients that you've been seeing for a long period of time who will continue to see you as an important piece of all this. And also those alternative revenue streams as ways of getting yourself through these tough times so that you're still up and running when all of this blows over. Does that sound right?
Yes.
Okay. All right. Awesome. What do we have for time here? Okay. And then I have a question here about e-visits across state lines. Since you're taking cash, I imagine that that's not necessarily a problem for you. What do you find?
Well, right now it's in flux, but we're still following telemedicine based on the Board of Medicine where we are. And what's required is you have to have seen this patient in your office. So, you know, for years we would get people from California saying, I've heard about your program, can I do it? It's like, you need to come here first. So they haven't relaxed that to my knowledge yet. You know, so we are not, you know, now our patients we saw in Florida who are now in, you know, Massachusetts or whatever, we've never had a problem with being able to see them and take care of them, certainly give them dietary lifestyle counseling and even, you know, suggesting medications to them. But they were established patients with us. But it is state by state, and right now they haven't relaxed that any physician throughout the US can see anybody anywhere. It's still required by your license.
Got it. Okay.
Been seen in Florida.
How do you think this pandemic will affect your practice long term? How have economic downturns and these types of things in the past affected? Is there a surge of people that come back? Do they trickle back? You know, what can we expect here?
Right. Well, there's so much nervousness, you know, being a business owner, a small business owner, we have a staff and everything. And it would always be like, we push on through. And, you know, one of the ways I got past it is I didn't look at the numbers. I let somebody else handle that. You know, I just like, I'll do what I'm going to do. And in the end, we were able to look back over 20 years and saw, oh, wow, even in 2008, our revenue wasn't bad. 9/11, you know, 2001, it's like in 2002, we had a phenomenal year. And it's like, but if you get caught up in the day-to-day, I don't have any patients, I'm not making the revenue, you're going to make yourself crazy. You know, it has to be really over the long term. Keep practicing good medicine. Keep learning. This webinar of listening to what Dr. Yanuck said about how important it is to help our patients not have chronic inflammation should inspire us that we should all be doing what we can to help our patients in a unique way.
Yeah, I love that. So trying to not worry about the day-to-day fluctuations and doing what you can to get through these tough times and knowing that things will get better, patients will come back. There's always going to be a need for, you know, functional medicine doctors out there. Okay, all right. Well, thank you, Dr. Cederquist. That was fantastic. I want to transition now to Dr. Greenblatt and talk about some of the mental health strategies that we can all use, I can use, to get through this very anxiety-provoking time. So Dr. Greenblatt, can you recommend anything for us? You know, in general, are you seeing this as well in your patients? Are they more anxious than normal? You know, what are you experiencing and what can we do about it?
Well, let me start putting on my epidemiology hat, and then I'll switch to psychiatry hat. With open hospital, where I'm having medical staff come and go and patients being admitted every day, we're seeing a lot of positive patients. So yesterday I participated in a conference with one of our medical staff who was ill, infected and sick with COVID-19. but she happened to be part of a Orthodox Jewish community. So it's a very tight-knit community. And in that community, there happens to be a statistician and 2 MDs. So they've been collecting data over the past month. And it was quite striking to me. And will lead to our mental health discussion, because they have data that they're collecting on 200 patients, 95 positive COVID patients. Many got very sick. And what was so striking to me, and they emphasized, is the variability in symptoms. And in the same family, a husband and wife, both sick. They do not have the same symptom progression, the same symptoms. They didn't come in the same order. And then I think it was only 67% had a fever. And we could go on and on. They listed a lot of stats, but this variability and individuality is kind of how I translate to how we have to understand how we treat our patients. Those that are struggling with mental illness, so our depressed, anxious patients, which are 20% of the population, and most of us who are anxious, who might not have had a diagnosed anxiety disorder, what happens? And I think how we perceive the threat and how we understand this illness really determines the impact. So I think the most important thing I can share is being really open with your patients and asking them what it is that they're thinking. And as Sam mentioned, the fear of death is certainly a part of it for many, but for others, it's my grandmother, my son, my dog, my asthma. And just like we've taught for suicide prevention, don't be afraid to ask the question. So I think it's critical in mental health for around this pervasive anxiety that no one has ever experienced before, to look at someone and ask them what it is that they're frightened of, so we can kind of help with their reality in determining treatment plan.
Yeah, and so how have you had to adjust treatment plans to accommodate for any increase in anxiety? Are you doing anything differently now?
Well, we've also had a telemedicine, practice for years, and it really was remarkable when I started it that you can feel the empathy and the affect and the tears, and so it does work. It is very powerful. So that has not really changed much. In the hospital, what is dramatic to me is the patients are doing better than the staff. Our patients are dealing with it, maybe by denial. It's the staff, like all of us on the line, that are struggling most with the anxiety. So the uptick in my patients, clearly some with OCD and anxiety, but there's not been pervasive change. We've had some suicide attempts due to people who've lost a lot of money in the stock market, and we've had some suicide attempts based on somebody who got sick and died. But overall, our patients so far have been doing a little better than our staff.
Interesting. What are your thoughts on this social distancing? I've heard that they're trying to reframe it now as physical distancing, right? Because we don't, we're socializing right now, and this is good. We need this interaction in our lives. We need to physically distance ourselves. What are your thoughts on that? And are you recommending that your patients, not isolate themselves and go for walks if they can and talk to people? What are your thoughts on social versus physical distancing?
Well, I mean, the most important thing, that we're pretty aware of it is certainly those with depression and social isolation dramatically increases risk for suicide and exacerbation of the depression. I guess we're fortunate that we have this ability to communicate virtually, and it has been a gift for our patients in the hospital, a gift for our colleagues and friends doing these groups and playing games, all different parts of the country. So that social connection is critical. Our brain needs those reciprocal relationships to function, and it's just been amazing to me, the tools we have available to us to prevent that loneliness. And for those that aren't interacting, we're going to know now, right? Because we're not getting the calls, we're not seeing these, and we can reach out to them.
Yeah. Have you found any activities to be especially effective? Games? You know, is there anything that in particular that you'd recommend that we all do, or that patients predisposed to mental health conditions all do to try to help keep themselves in a little better place?
I think staying connected is probably the theme, but
Yeah.
going back to that concept of our work in every aspect is everyone's different, and that uniqueness really is important in terms of how we virtually connect. And so we have some people playing trivia games on Zoom with people around the country, and other people just using the FaceTime with their loved ones. So I don't think there's one secret way of staying connected, but as clinicians, making sure that we help our patients find those ways.
Okay. All right. I'm getting some questions about for Dr. Cederquist and for Dr. Yanuck. I want to, for the sake of time, circle back and answer as many of these as we can before we have to sign off here. So let's see what we have. We did talk about snacking and eating a little bit. Do you have any advice, Dr. Cederquist, for addressing those tendencies to be in the kitchen every 15 minutes? What can we do to stop ourselves?
Yeah, it's definitely something when you work from home. A lot of times, you know, even people who, you know, they're still working, but from home, it's just going in the kitchen every time there's a break, or just wanting a mental break. I really think the key is trying to stay to a structure, you know, trying to create a plan, whatever that's going to be, that it's breakfast, lunch, dinner, 2 snacks, certain time. When times are uncertain, having more structure really tends to help much more than not help. So I would encourage our patients, and even everyone listening here who's working from home, is trying to create that, you know, at 8 o'clock I have this, and whatever it's going to be, so it's not unlimited back and forth to the refrigerator, because those calories add up for sure.
Yeah. And the next question I have for you, Dr. Cederquist, is about the telemedicine platform that you're using. Are you happy with the current telemedicine company that you're using, and would you recommend it?
It's too early to tell. We like some things about it. It allows people to like go into a waiting room, and then the staff, I mean, they're all working from home, so that the dietitian can pull up and know somebody's waiting. But what we found is that it seems to be more robust during the morning, and then it filters off during the afternoon. We don't know if that's the amount of people using internet and the places where people are living. But other staff members have instead decided that they're going to do their visits via their smartphone. You know, they're just going to do a FaceTime call. And if that's not working or not able to be done, they're making a phone call. It's sort of like, you know, good, better, best, you know, whatever we can make happen. So there's some things about it that are good. Apparently, the standards for HIPAA have been relaxed so that it is permissible to have calls over FaceTime, which maybe that was a problem before or something like that. So the jury's not out on all of it yet.
Yeah.
I just mentioned I've been using a platform for 5 years now, a secure telehealth. They've been in the business for 10 years, and they go through a Zoom platform, and and with 24-hour support, because we do admissions in the evening. So secure telehealth, great company.
Thank you.
Yeah, very good to know. Thank you, Dr. Greenblatt. I want to open this next question up to all 3 of you, because I think it will require a lot of brain power to answer. We're getting questions from chiropractors and from acupuncturists who are more hands-on in the way that they practice medicine. So what do these doctors do? What can we recommend for them in times where you can't get close to these patients? So I'll open it up to you, Dr. Cederquist, and maybe, you know, if you guys have anything else to say, Dr. Yanuck and Dr. Greenblatt, I'd love to hear from you.
I don't know. I had the most wonderful chiropractor. My son and I were rear-ended by a bus about a month ago, and helped us tremendously. I decided to cancel my visit this week, because when he's doing an adjustment, you're like forcibly exhaling onto him, and as are all of his previous patients. But my husband, who was in agony due to a rib displacement, ended up seeing him, this week, and he was helpful. So what I've decided is I'm feeling pretty well. I'm going to try to defer that appointment. But yeah, it's tough.
Yeah, going back to your earlier point about alternative revenue streams, books, supplements, courses, whatever, I mean, and the importance of that, and getting creative. I've also heard of, a lot of organizations offering discounts on future appointments as a way to bring in revenue now when you need it. So if you can buy a gift card and get, say, 20% off, 15% off a future appointment, right? That's a way to kind of get a little bit of a revenue stream. Dr. Greenblatt, Dr. Yanuck, any thoughts? This is a tricky one. I certainly don't have the answer.
I don't have an answer. I don't have a way of having that interaction not be a source of contagious transmission.
Yeah.
I do think that for many people, their chiropractor is a central source of information and guidance broadly, and is a person they trust. And all of that value of the interaction can be conveyed through a remote session.
Yeah.
Even if the mechanical utility is not something that can be conveyed. I mean, I can tell you that my chiropractor is forever giving me rehab exercises for mechanical stuff, from old sports injuries and stuff like that, reinforcing that, even watching me do stuff like that over, Zoom or whatever, it is of significant value. And just as Dr. Cederquist was saying, the connection and the maintenance of the structure of what their plan is something that can be conveyed remotely.
I would agree.
Okay, so we have a couple more questions. I know it's 5 o'clock. We did start a couple minutes late here, so I'm going to let us go a little bit longer. But here's some more immune-related questions, so perhaps more for Dr. Yanuck, but I'm certainly open to hearing from everybody. If you suspect exposure, Dr. Yanuck, is there anything that you should do? Is there anything you can do?
Sure. Well, I think going back to the two basic questions, how to not get infected and how to not die if you get infected. I think that the strategy for attending to question number one is to stay home. That's the most decisive thing to do. And in terms of parsing your experience if you get infected, I would reiterate what Dr. Greenblatt said, that there's enough variability that you're not going to be able to logic out, oh, I understand exactly what's happening because I feel such and such a way. So what it goes back to then is fundamentals of immunology, which is to support natural killer cell biology with things like astragalus, andrographis, reishi mushroom, which is also called Ganoderma, black currant seed oil, vitamin C, which can be done in high dose, and even, get a bag of oranges, get a bag of peppers, foods that are rich in vitamin C. Try to keep your stress level low and try to reduce the chemistry of stress, because the chemistry of stress causes programmed cell death of natural killer cells and Th1 cells. So valuing adaptogens like ginseng and ashwagandha and things like that, so that for however much stress you have, you don't pump out an enormous amount of cortisol and norepinephrine. So try to keep your stress level low, promote natural killer cells, promote Th1 cells with things like berberine and bicalin, echinacea, things like that. But do that while you are inhibiting inflammatory process, because you want to make sure that your maneuvers to advantage your immune system are matched with maneuvers to quiet down the inflammatory nature of killing pathogens. That's the business about keeping enough headroom so the crescendo of your immune response doesn't spin you up too high. And that's the value of the substances that do both that I talked about before. And in fact, a lot of the things I just mentioned, the natural killer cell promoters, the Th1 promoters also do that. So those are your moves. Now, if you begin to get accelerating disease, you have to realize there's a moment when you have to say to yourself, my natural approaches may not be enough for this. right? You have to say to yourself, okay, I'm using tools to give myself advantages, but that doesn't mean the tools are going to work. They're not going to work every time for every patient. People are going to have various experiences. You have to get, recruitment of conventional medicine tools and approaches when it's appropriate. And you have to also recognize that if the patient starts to get an accelerating process, if you keep dosing them with things intended to improve immune surveillance, and if those things push their inflammatory process higher, then you may be getting the patient in more trouble. So you want to have a protocol or an approach, a way of trying to understand it. But then if things escalate, you have to say to yourself, which of these things am I safe with to push back with a higher dose of? And tops on that list is going to be things like glutathione and NAC that are normal to the body and that are profoundly anti-inflammatory while giving surveillance advantages at the same time. But fundamentally, the fluids that line the lung epithelial cells, the higher the glutathione content of those fluids, the less inflammatory process the patient will have. Okay. So, but at a certain point, you're going to tip over into saying, you got to call the hospital and see if they want you to come in.
Yeah.
Okay.
So for the sake of time, I want to play us out here. The Calling Connection Part 2, which is scheduled for next Thursday, April 2nd at 4 p.m. live. So same time, same place. We'll have 3 new panelists. We're going to be joined by Dr. Peter Bongiorno, Dr. Penny Kendall-Reed, and Dr. Felice Gersh. They will all be lending their unique expertise to help us understand and survive this event, this pandemic. So I hope you've enjoyed this lecture, this gathering here, and I hope that you are considering joining us at the next one next Thursday. I do want to be clear about one last thing. There is no coupon code for our Colleague Connection seminars. We will not be distributing coupon codes for these seminars. They are strictly for educational purposes only. We hope to bring you together and share some information. Again, I do hope you learned something. I hope this was helpful for you. And on behalf of Pure Encapsulations and the entire Atrium Pro brand family, I'd like to thank you all for joining us today. And to our panelists, thank you so much for sticking with us, for answering all these questions, and being so supportive in these uncertain times.
Thank you, Paul.
Thank you.
All right, take care, guys. Have a great rest of your night. Take care, everyone.